We now move on to our next speaker, Dr. Shail VASAVADA, and he's going to talk about anterior vitrectomy, how to do a posterior capsular Rhexis, and optic capture. Over to you.
Yeah. Thank you so much, Dr. Priya, for conducting this wonderful course. We do receive research grant support from Alcon Laboratories, but has no relevance to this presentation. So this was a 30-year-old male who had complaints of glare while night driving, and he was diagnosed as bilateral posterior polar cataracts, right eye more than the left eye. We prefer doing the femto delineation, which means we divide the lens into multiple zones or rings, therefore it acts like multiple hydro delineations without actually having to do that. And we followed all the principles that Dr. Bobby Osher has taught us over the years of maintaining a closed chamber, using low parameters, and making sure that the posterior polar part is not exposed right up to the last point. So here we are removing one epinucleus shell from the support of the other, so that until this last epinucleus plate is there, the posterior polar part is not exposed. Here what we are doing is we are just detaching this from the fornice, and this allows fluid to trickle down, which Dr. Bobby Osher described as the escape sign. So now even if you kind of come out and do hydrodissection, the chances of rupture are very minimal, because rupture occurs with hydrodissection when there is a raised intralenticular pressure. So here, because there is a communication created, you can still now go and hydro if it's a thick epinucleus plate. Make sure that you always inject dispersive viscoelastic before bringing out any probe. And fortunately, we followed all the principles. Bimanual irrigation aspiration definitely helps in such situations, so that there is less chamber collapse, as well as you can access everything on both sides. And fortunately, the capsule maintained as we hoped it would be, and we have a nice centered capsular Rhexis. But sometimes when you do many such cases, you get overconfident, you get greedy. That there is this small little plaque and this is a young patient. Let me just pull out those fibers and they will come off. I won't touch it. And then you get greedy, and the moment I try to pull them up with vacuum, I've created this nice split, which we all dread occurring in a posterior polar cataract, which I could have easily avoided by not touching the posterior capsule. So now, since I've already done it, I still now have to go back and get calm again. So make sure that the irrigation is on, and I'm going to inject dispersive viscoelastic at this point of time, because dispersive viscoelastic is one which stays. So cohesive viscoelastic, which is like sodium hyaluronate, can come out as a bolus as soon as you bring out the irrigation. Once I've made sure that the chamber has been well formed, I have this slit tear, which I still have an option of converting into a posterior capsular Rhexis, because it's still very much within the central capsular Rhexis area. So it's not gone up to the equator. So now I'm injecting cohesive viscoelastic because I want some weight on that posterior capsule and pushing the anterior vitreous face down. This is the time when we need micro instrumentation. So these are micro incision Rhexis forceps. Grab one end, because these edges are the ones which can split. So you want to convert these edges into rounded edges, so that they will act as strong margins for a capsular Rhexis. So I've started from one end, and I couldn't unfortunately reach and completely cover the other side. I finished a little bit in front, so I have to now make sure that I go ahead and convert this edge also into a rounded capsular Rhexis margin. So I'm gone through my other side port, making sure patient is under topical, so using a spatula to control the globe position. And now I've converted both those edges of the PCR into a posterior capsular Rhexis. So this will now act as a strong margin. It is almost like an anterior capsular Rhexis. So now, since there is no vitreous disturbance, we can go ahead with our plan of in-the-bag IOL implantation, which in this case was a trifocal which was planned for this young patient. So we go ahead and place the IOL inside the capsular bag. Here it's important to have an IOL which opens up slowly, so you have sufficient time and it doesn't open up in a jerky fashion. And once that is done, you make sure that the haptics on both sides are behind, and as luck would have it, it was also toric, multifocal toric. So through my microscope, I am looking at the digital alignment system and making sure that the IOL is aligned to its appropriate axis. Obviously, you are not going to be foolish in going behind the IOL to remove the viscoelastic in this situation. And post-operatively, you can definitely go ahead and give mannitol to such patients to dehydrate the vitreous and whatever viscoelastic that has gone behind this posterior capsular rhexis. And this is the on-table picture, centered IOL with a centered capsular rhexis at an appropriate place. And this is the patient doing now 6 months, almost a year down the line, well centered. The IOL has not rotated, and he is going to maintain a clear visual axis for the rest of his life. You do monitor these patients for macular edema and peripheral retinal plaques, which fortunately didn't occur in this patient. So the most important lesson that I learned was that never touch the capsule of a posterior polar, however many lakhs of surgeries that you may have done. When there's a small PCR, you still have a chance of converting into a PCCC and before it enlarges further. So having learned the lessons from the previous case, I approached the second posterior polar cataract, and this is even more risky. You can see these granules all around, which means there's a higher chance of creating a capsular rupture in this case. So I followed all the dictums, all the principles, went ahead with flax. Fortunately, right now the capsule at least appears intact. We went ahead with the multiple ring pattern division. The surgery went off perfectly, and I followed what my learnings from the previous case of not touching this plaque. I can always yag it later. So now I'm going ahead and injecting this IOL, and I'm struggling a little bit. If you noticed here, it's kind of the cartridge has actually come out of the wound, but I think I can still manage. Once again, I think I'll go ahead, I'll push it back in, and I'll be able to do it. And oops. So not only did the IOL get stuck, I also had a dip of the IOL, which means it touched the posterior capsule, which I wanted to avoid touching. So now in a panic mode, what do I do? So the first thing is I don't want to try and push or pull this IOL again. So I thought, let me just enlarge this incision a little bit. So I'll release the stress on the IOL. So at least I can safely push it in and see what the situation is right now in the other part. Once trying to do that, I do realize that there is this large capsular dome that you see here. That's the PCR that I've created. So now I am in a fix. I have a single piece IOL, 3/4 of it is inside, one haptic is outside, and I have a PCR. So the first thing that I'm trying to do, having learned from the previous few cases, is to try and convert this ragged edge into some sort of a strong margin, so that even if when I do vitrectomy or if I try to do something with the IOL, whether it's explant or doing it, at least I have a strong margin that it doesn't extend further. So I've picked up this flap and I've converted it into a rounded edge, which means at least one part of this area I'm sure I'm not going to extend further. Now I know with so much of manipulation there is likely to be vitreous in the chamber, and therefore our approach is to do a pars plana approach, and to insert a trocar in an open eye is not easy. So you have to suture the wound and make sure that the eyeball is tight, and you go 3.5 millimeters behind the limbus, and you do need a little bit of force, but it does tend to occur. So I've made sure I've kind of inserted the trocar. And this flap from the other side, fortunately now I could visualize. I've also made sure that I've converted that also into a strong margin. So now my chances of extension of this tear are very minimal. The only way to identify the presence of vitreous is to inject triamcinolone. And you'll notice the advantage of pars plana, that with the irrigation from the front and using the vitrector from behind, you'll see that there is no turbulence that is occurring, and this entire blob is getting drained through this PCR, and slowly you'll see that this flap will start fluttering in the AC, which means the connection between the anterior and the posterior component will be severed. Because very often when you approach from the limbal route, you do tend to drag out more and more amount of vitreous from the anterior chamber. So I've made sure that I've severed the connection between the anterior and the posterior vitreous connection, and you'll see this now flap of vitreous which is stuck in the incision on one side, but it's floating. I'm just using the irrigation to highlight that it's now severed from its posterior connection, and now therefore you are unlikely to disturb more vitreous, and this further you can just remove it from the incision from whichever way is more appropriate. Further, we do a further vitrectomy not just in the area of the PCR but all around, so that symmetrical amount of vitreous is removed from the area of the PCR. This is all viscoelastic, dispersive, which is quite difficult to remove. And now at least I have a strong capsulorhexis, and now I can think of converting this, putting this IOL in. I'd like to credit my colleague Dr. Samresh, who brought out this wonderful teaching video to show that when you approach the vitreous from above, that is the top-down approach, you are dragging more and more amount of vitreous, and what started as a small PCR typically ends up being a large, ragged, irregular tear, which becomes very difficult to convert. Compare that to the pars plana approach, where you're dragging the vitreous from where it's actually coming. You're attacking less amount of vitreous and it drains through that area of PCR, so you can notice very little turbulence, very little change in the site of the PCR. So that's something that I learned, and now I want to make sure that I put the IOL inside the bag, so I'm making sure my visibility is good. So I'm using iris retractors in this area to confirm that the PCCC is complete on this side. So again, a take-home message is, do not hesitate to use whatever is needed at that point of time. At this point of time, I needed iris hooks, so I used the iris hooks. And here I am gently making sure that I push the optic haptic junction behind the anterior capsulorhexis, and making sure that it remains behind, and making sure all around that the IOL is in the bag. Always reconfirm after any manipulation that there has been no further vitreous disturbance, which fortunately there wasn't in this case, and hydrate all the wounds before the chamber collapses again. Take as many sutures as needed. This is not for aesthetics. Whatever it takes, you do it. And this is the patient now more than a year down the line. This is the PCCC that you see. There was a dent in the IOL. The plunger had overridden on the optic, and therefore it got stuck. Fortunately, it's out of the visual axis area. There is some PCO that is developing in the intact capsule, but so far hasn't required a YAC capsulotomy. Coming to this, another case of a 42-year-old male scheduled for second eye multifocal IOL with a query posterior polar. Once again, things have gone off very well, and now I'm injecting the IOL, and if you notice, I hesitated a little in injecting, and the IOL has just become a little vertical. But it's under cohesive viscoelastic, so I've managed to make sure that it goes back again, and there's absolutely nothing that has gone off which I think is inappropriate. So IOL is once again in the bag. This is in retrospect. Having analyzed this video, this blob appears suspicious, but I could never notice that on table. So since I thought everything is perfect, I go ahead with my normal technique, irrigation behind the IOL, to make sure that all the viscoelastic gets driven out and we have an empty posterior bag. And that was the blob that was missed, and now I have a single piece multifocal in the capsular bag with a tear extending up to the equator on one side and on the other side, second eye. So now what do? First of all, you pray that nobody has seen this and this has not happened. So that's what I did. I hydrated the wounds, and I thought God is kind and this IOL will center. Nothing has happened. So I tried centering the IOL, didn't work. So eventually I had to take the decision, injected triamcinolone, and obviously with so much of currents of irrigation aspiration, the vitreous was disturbed, as you can see, and it's coming from the area of the PCR. Whenever there is vitreous, you have to attack it, and the best way to attack it is through the pars plana. And you'll notice once again the advantage is that I'm draining it from the area of the PCR, and slowly but surely you'll see this vitreous getting sucked in beautifully through this PCR, although it's not, at that time it didn't appear beautiful, but we are making sure that the vitreous gets drained through the area of the PCR, and slowly but surely once again you'll see this flap fluttering up again, which means the connection between the posterior component of the vitreous from where it's coming and from the anterior is getting severed. So make sure that once that is severed, you can remove it from the incision from whichever place you like to, and then go back again and do further vitrectomy all around the PCR to make sure that symmetrical amounts of vitreous is removed from all sides. It looked stable on table. I'm still praying for the next day to see how this eye is going to behave. Fortunately, we had counseled her for all possible things, and being a second eye, we were a little more relaxed that we have the patient at least with us. This is 7 days, this is 3 months, and this is 6 months. Even the rest of the capsule has remained clear. PCR extending up to the equator, very well centered in the bag IOL implantation, and that's because of adequate symmetrical vitreous removal from the pars plana all around. And this is the UBM of the same patient at 6 months, showing no tilt of the IOL. The IOL is very much in the bag, and no internal aberrations, which means even clinically the tilt is minimal. All of these patients need to be monitored by your VA surgeon. You want to make sure at 1 week, at 1 month, at 3 months that they indent and see at the periphery to make sure that if any break event has started, that can be handled or tackled at that point of time at an early stage before a retinal detachment occurs. And these patients are more likely to develop cystoid macular edema. So don't worry about as many times as you may have to do a free OCT for this patient, as many times as required in the follow-up. And this is what I meant by removing symmetrical vitreous from the pars plana approach. When you're doing from the limbal, however much you may change your hands, it's very difficult to remove equal amounts of vitreous from around the PCR, and therefore you leave behind unequal pockets of vitreous, which eventually leads to subtle tilting of the IOLs and other inflammatory components. Whereas when you are approaching from the pars plana, you can not only drain the vitreous from there, you have much more ergonomic access to all around the posterior capsular tear, so that you can remove symmetrical vitreous from all around, leading to a more stable IOL. I can stop wherever yeah, okay. So this was a 65-year-old male, right eye cataract surgery done in 2017, now planned for the second eye, grade 1 nuclear sclerosis. And everything seems to have gone off well. We are doing the irrigation aspiration removal, cortex removal with our bimanual technique. And if you notice here, while doing this, I can see a little kind of line here appearing, which is far too clear compared to the rest of the capsule. So this is something that's already a warning sign appearing, 2 lines. The Rhexis is intact, but this is a very, very clear area that is there, and you can notice some shadows appearing as well. So definitely the capsule has been breached in this area. And the surgeon is still little oblivious of the fact that this event has occurred, and things are going off as per routine. Finally, it seems that things have been noticed, and you can notice here now you have an equatorial PCR, some amount of viscoelastic, maybe a little bit of mixed with pigments or something is already there in the anterior vitreous phase, with an intact capsular Rhexis. And this patient is planned for a single piece IOL for his second eye. Wherever and whenever there is a vitreous disturbance that you suspect, you must tackle it at that point of time. And even this was a 2.2 millimeter incision. I sutured that wound before I made sure that I injected the trocar so that the globe is relatively well formed. You need a good anesthetist because this patient was under topical anesthesia, so he was sedated more. And once again, in the area of the PCR and all around the area of the PCR, keep a very low bottle height, a very low flow rate of 10 cc, and a vacuum of around 200 to 250, and have the maximum cut rate that your machine offers, whatever that may be. Here it's 5,000, it could be 2,000, 3,000, whatever the maximum cut rate that your machine offers, go ahead. You don't want to get very close to the intact posterior capsule because you can cut it very quickly if you're not used to doing a vitrectomy. So angle your vitrectomy probe a little bit more posterior. But you do need to remove vitreous even around this PCR. So the PCR is here, I'm removing some vitreous below the anterior, intact posterior capsule also. And once the vitreous has been tackled, you can go back to your bimanual irrigation aspiration as well. Since this patient was planned for a single piece, I know, equatorial PCRs are very notorious. So my plan right now is to try and put the IOL in the bag and orient the haptics in the other direction so that I can get away with that. But even with that, I'm finding that I'm probably not going to have a very stable IOL position. So having placed the IOL in the bag, I'm going back again and making sure that I once again remove any vitreous connections that may have occurred during my IOL manipulation. So going ahead in the area of the PCR and around the PCR and doing an adequate vitrectomy. And once that is done, to improve the stability, I'm thinking what can I do to make sure that this IOL doesn't move or it doesn't dislocate with time. So I'm going ahead with what I've learned actually from Dr. Priya Narang, with whom she published reverse optic capture. So this, in conventional optic capture, you have the haptics in the sulcus and the optic captured through the anterior capsular rhexis. In the reverse optic capture, you have the haptics in the bag and you are trying to pop out the optic above the IOL. Because a single piece IOL cannot be placed in the sulcus. The haptics are too bulky to be placed inside the sulcus. So I put my irrigation probe behind the IOL and with my Lester hook I am making sure that I am kind of bringing the optic first in the center and then trying to pop it out above the anterior capsular rhexis, and you will see this broad band, unlike with a 3-piece IOL where you see a very narrow dumbbell kind of appearance. Here you will see a broad band because the optic haptic junction is very broad in a single piece IOL, and it is challenging to perform, particularly if your rhexis size is on the relatively larger side. Fortunately, I found that the capture was remaining stable. This is the PCR and this is the reverse optic capture with the haptics inside the capsular bag. Post-operative day 1, except for the areas of subconjunctival hemorrhage, the eye looks very quiet and clean, and except for me and my assistant, nobody knows what happened. The patient doesn't know what happened, and this is the reverse optic capture. You can see this area of the PCR which is crystal clear. Rest of the PC will develop early fibrous PCO, which you can definitely YAG as and when required. And this is the broad area of optic haptic which has got reverse optic captured. Patient did quite well. This is the anterior segment OCT to show that the optic is still very much behind the iris, so no chances of uveitis, glaucoma, hyphema occurring. So pars plana did come to the rescue, and reverse optic capture of a single piece IOL, although difficult, is possible, and I think it's an important tool to have in a surgeon's armamentarium.
Thank you so much, Dr. Shail. That was so enlightening. It was a wonderful talk. Well, I have 1 or 2 questions for you. Could you just highlight the instrument that you use to do a posterior rhexis?
So it's nothing fancy. It's a micro incision capsular rhexis forceps, which we actually designed with Indo-German. I don't know what name they call it in, but it's a micro incision capsular rhexis forceps with no financial interest. We use the one made by Indo-German.
Okay. Yeah. And for the optic capture, I would just like to, for the benefit of the audience, I would just like to say that having what Dr. Shail showed was real beautiful, but it is actually difficult to do it with a one-piece intraocular lens, because the moment you try to bring this and try to capture it, if you do it from one side, it slips from the other side, and eventually it goes back again. So, and as Dr. Shail highlighted, the size of the capsular rhexis is very important. The bigger it is, the
absolutely. So you need a very, if you find that your capsular rhexis is large, do not attempt it, because it won't stay. Even if you think it is stayed on table, the moment the IOP in the eye changes, it may decapture and fall back.
Absolutely. And actually, whenever we have all these cases, where we are doing an optic capture and settling up things, and whenever there is a vitreous and we have done vitrectomies and all that, whenever we hydrate the wounds, before you leave that, you close the eye, you should have a brief outlook of what actually it's looking like. It should be stable at that point of time. If you have a 1%, because we all have a sixth sense coming in that, okay, this might have a problem later on, it means it will have a problem. Absolutely. There is no way that it will not have a problem. When you leave the patient, you should have a feeling, now this is going to be okay, nothing wrong with this right now. So I think that's very important. I would like to invite audience for questions to Dr. Shail. Meanwhile, Dr. Lalit Verma, sir, could you please go ahead with your next talk? So, yeah, yes, Dr. Gadre.
Yeah. Shail, as usual, wonderful talk. I was just wondering, in that particular case where this is the second eye where you are doing panoptics,
Yes.
and there is a posterior capsule rent. And unfortunately, even the anterior capsule is torn at a point.
Yes, sir.
And you have placed the lens. And unfortunately, next day, the lens is in the vitreous. The other eye has a panoptics. Now, have you or anybody tried putting panoptics in the sulcus? Because the modern lenses, the Clarion lenses that we implant, the loops, as we all know, they are not as thick as the previous one. And secondly, they are extremely soft because they are almost like the hydrophilic haptics. So is there any experience of putting panoptics? Because you have done panoptics in one eye.
Correct, sir.
Here you have to remove the lens. You don't have a three-piece
Absolutely.
trifocal available. You just can put a monofocal in the sulcus.
Correct.
But then you have to do a lot of explaining later on. Fortunately, as you said, one eye you have done yourself. So patient is understanding and all that. But we had one experience and we are following that.
Okay,
Now it's more than 2 months. And 2 months is a very short period for these lenses to
Correct,
create
sir.
mischief. So I just want to know, I haven't seen anybody in the literature doing a panoptics Clarion lens in the sulcus. But right now the eyes are absolutely quiet, and surprisingly there isn't much refractive surprise as well,
Okay.
because the anterior chamber is deep, it hasn't shallowed or anything, or there is no pupillary block. Even your comments, Priya. Can
Maybe
you-
with the newer materials, we might still have to evaluate that. But
Yeah.
as far as the general rule goes, never put any lens
I know,
which has
I know.
Yeah,
which
yeah.
has an acrylic thing.
That
Never
is-
put it in the sulcus. Believe me, before I came to the conference, one day before I have explanted an intraocular lens, surgeon had probably put it into the sulcus with those acrylic lenses. They are just not forgiving to the sulcus.
This-
So I don't know about the Clarion
This
as you are
material
saying.
looks different. This
Yeah.
is Clarion
Maybe
material.
it needs
is-
to be evaluated.
Yeah, yeah. I mean, no
And-
personal
Yes.
experience of single piece.
Yeah.
And because Dr. Lalit is also here, there is one question I always feel when I listen to your talk. You always say that when you're doing a pars plana vitrectomy,
We will
you
come to
have
it.
you have a symmetrical cut all around.
I think
Now
we will
you
talk
don't
about
see it. Actually, what you are doing, you are seeing only in the pupillary area. And how can you be sure that you are doing more
Symmetrical.
vitrectomy on one side than the other?
So, sir, that's true. There is no end point as such that we can judge. But at least if you stay there, if you keep a mental clock in your mind that 10, 15 seconds here, now 10, 15 seconds next point, 10, 15 seconds third point, you try and at least follow that principle of doing a
Sanjay, you
circular.
are
But
Absolutely,
vitreous at that particular age is degenerated.
Correct, sir.
It's floating so freely. If you have, intraoperative sonography, you would realize that the vitreous is moving, dancing away. So it would be a myth to propagate that we are cutting vitreous, surrounding all the areas. I accept all other
I agree,
points.
agree. So I
that you
think
said.
that's an extremely valid point. This is something that we feel we are doing better with this approach, and probably not all vitreises are so liquefied. Quite a few of them do have some jelly as well. So, but I think I agree with your point. There is no evidence or there is no proof.
I would like to settle this. There is a VR surgeon and there is an anterior segment surgeon. So the anterior segment surgeon will try to cut off everything that comes up into the pupillary plane and slightly behind it. They won't be going beyond that. So as a VR surgeon, you and Dr. Lalit,
Sanjay, your observation is absolutely correct.
Yeah.
You see, this is a blind kind of vitrectomy. We do not see the vitreous unless it is stained with
Stained.
triamcinolone.
Yes.
Therefore, Shail was very nicely emphasizing in the anterior segment, yes. Even in the posterior segment, unless you put triamcinolone, you do not. And sometimes you have to repeatedly inject that. And the only thing is he is stressing on symmetrical this thing. It may be asymmetrical, but still it is better than doing it from anterior segment.
Absolutely.
I 100% agree that you see gel is there. Every vitreous is not a sol, it's a gel component there.
Yeah.
So
Thank
thanks.
you so